We have the honor today of having a friend of mine, Jose Canseco. He's a close friend. For those who don't know, Jose, he's a Harvard educated, then did a fellowship at Rodman in spine surgery, and actually is an assistant professor of orthopedic surgery at Thomas Jefferson University in Philadelphia. So thanks, Jose, for being with us. It's a pleasure. We share the knowledge forum trauma and infection. So I heard a lecture from Jose about infections that was blow my mind. So I asked him for repeat here, and he kindly accepted. So Jose, thank you again, and please be our guest.
All right. So hello everyone. Again, Alfredo, thank you so much, and the Virtual Spine Group for having me. This is, advancing the message that Alfredo and I have been working on for a long time with the knowledge forum and trauma and infection, and it's a topic that been discussing quite a bit over the past recent months, and we're doing a big study at Rothman and Jefferson with many other institutions, and so we wanted to share what the worries that our group has, and what are the things that we're trying to tackle and how we're trying to tackle those. And then we're going to go into a few cases. I think, Alfredo, you may have a few cases that we may discuss, but I have a couple too. So all in all, I want to talk about how we developed this classification, and so why is this a topic of importance? Originally, this pathogenic infections were predominantly caused by granulomatous spondylodiscitis, and more lately, pathogenic spondylodiscitis is more prevalent. And as the global incidence of these diseases is increasing, there's more elderly people, there's more immunocompromised patients that with medication are able to withstand longer periods of time with their disease. Then we see this more often in the hospital. There's also a lot more people using IV drugs, and that's usually people that present with this condition. And it's dangerous because up to 20% of people can die from this. And we've definitely seen this at Rothman over the past several years. There's an increased prevalence of these infections in our hospitals, in our cases, particularly over the past 10 years. And so that's why we started focusing on this. So why is this something important? Is because oops, sorry, yeah, I moved it. There's really a lack of consensus of what is universally accepted as a way to treat this. What we do in the US is different than what we do in Europe, even what they do in the UK, South America, Alfredo. So we have to make sure that we all come up with a plan that does good for the patient. There's regional variability, and also there's institutional variability, provider-specific variability, and that's where we're trying to come up with that consensus. So a brief summary of the way things are done right now. Pretty much standardly across Europe, the US, and South America. First, we start with conservative treatment, and Alfredo, correct me if I'm wrong, but I think that what we try to do is long-term antibiotics for 6 weeks once you diagnose. You try to target specific pathogens, but a lot of the times, initially, you want to cover MRSA and gram-negative organisms like vancomycin and a third or fourth generation cephalosporin. If you have the availability, you want to consult infectious disease, you want an expert that is able to help you target that therapy. And then you monitor long-term, you do clinical symptoms and also laboratory markers. We use ESR CRP, and the problem is what is an endpoint, right? There's limited data regarding what are the endpoint is when you're done treating the disease, or when the patient's recovered, and that's where we come in. We're trying to figure out a standard method of trying to identify these points. And so when that conservative management fails, the interesting fact is, when do we move on to surgery? When is surgical indication necessary? And we all know that when there's neurologic deficits, either progressive or severe, that's when you have to proceed with surgery. This is a study that we did with our group. Sebastian was leading our group. Also, if you have evolving instability of deformity, as the patient has more bony destruction, they get progressively kyphotic, then surgery may be another reason for an indication. A third important one is an epidural abscess, right? If you have a cervical or thoracic epidural abscess, many of us worry about potential for vascular compromise, and then you may be more prone to taking the patient to the operating room sooner than later. Whereas if it's a lumbar epidural abscess without deficits, you may be able to wait a little longer. Another one is how sick the patient is. If you have septicemia, and you need to, curb the source of the bacteria, then that may be another reason to take the patient to the OR. Or sometimes the bacteria is in a place where CT cannot get a biopsy, or where the patient's unable to get a CT guided biopsy at a facility, and so you need to do an open biopsy and culture. Finally, if you have intractable pain, there's many patients that show with severe pain from bony destruction, or they have the inability to mobilize, then surgery may also be a reason to indicate it. And remember, all these are soft indications because it's institutionally dependent, regionally dependent. Some of us have higher thresholds than others, and so that's why we got to be careful. And the finally is, well, failure of conservative treatment, and that's why I have a slide later on well, what does it mean to have failure of conservative treatment, and that's where you get repeat imaging, repeat lab workup, repeat cultures, and we still don't have a consensus. Now, so what do we do when it is surgical management, and when? So traditionally, early on, when you have a patient that's decreasing, worsening neurologic deficits, or getting more ill, so you want to do early operative intervention to accelerate clearance of the bacteria and prevent spinal deformity. There has to be, and then there is a difference between stable patients and critically ill patients, right? When you have a critically ill patient, sometimes you have to move faster or slower depending on where they are, if they're in the ICU or not. A little bit more on that later. But if they're stable, then early or late has a different definition depending on the paper. There was a recent study by Santoshi and Dr. Davis on what's the role of early surgery, and it was quite controversial. It's a meta-analysis. They had 11,000 patients in 21 studies, and their key findings were pretty striking. Early surgery reduced mortality by 39%, lowered the risk of treatment failure or relapse by 40%, and shortened hospital stays by more than a week. And that, on the surface, this strongly supported that early surgery in the disease scores was appropriate for appropriate surgical candidates, was good, and it was better than delaying it with conservative management. The problem was the definition of early surgery for the 21 studies was not standard, right? It was inconsistently defined. Some people said early surgery were 24 hours, and other ones within 2 weeks of diagnosis or even hospital admission. So not even diagnosis or hospital admission were standardized. And so that non-uniformity limited the ability for us to apply this knowledge across the board, right? The precise timing were not clear, and the heterogeneity of the data was not clear. And so even the authors acknowledge this. Despite that, their findings are interesting. If you operate soon, you can decrease poor outcomes. Another study that was very important recently done was a study that they did in the UK and Germany comparing surgical and non-surgical treatment. It was about 400 patients. In the UK, the consensus is treating it conservatively with antibiotics. And in Germany, they tend to be a little bit more aggressive and taking people to the OR sooner. And the primary outcome was mortality. Secondary outcome was length of stay and relapse and neurologic status changes. And then the study was pretty significant. The mortality was significantly higher when you treated people conservatively versus surgically. You can see the numbers on the screen. And surgery led to significantly shorter length of stay compared to conservative management. The interesting fact is there was no real change or difference in neurologic deficits between the two treatment groups. So this told you that, if you have patients with an infection and you treat them with surgery, for the most part, they're going to do better. And so that's an important finding. Another point that I wanted to touch is, well, what happens when the patients are sick? Many of these patients can be elderly people with immunocompromised status, or IV drug users not in the best state of health. And so when they're ill, well, what happens if you take the patient to the OR too early? And there was a study done that published in the Spine Journal this year, where they compared, okay, well, when you have a critically ill patient defined by having, at least two SIRS criteria, 2 out of 4 SIRS criteria, either CRP of more than 200 and a temperature of greater than 38 degrees Celsius, heart rate more than 90, respiratory rate more than 20, and white blood cell count more than 12,000. If they met that criteria, they were critically ill, and they differentiated a couple of outcomes. One was 30-day mortality, and a secondary outcome was ICU, length of stay, and relapse. And they had 3 groups. One group was the early surgery within 3 days of admission. Then the late surgery was considered more than 3 days of admission. And then the third one was conservative management. And then they were able to do almost 200 patients. And in this setting, when they did delayed surgery in critically ill patients, and this means 3 days after admission, there was a significantly lower mortality rate compared with people that were operated on early or with conservative management. And also delayed surgery was shorter hospital days, length of stay, and shorter ICU stay. So this tells you that when the patients are sicker, perhaps you don't have to intervene right away. Having an optimal window of 10 to 14 days to let them stabilize and then do surgery allows them to do better than when you have a stable patient that is not sick and you do early intervention. This, of course, the risk factors that were associated with this were, age, multi-organ failure, vertebral bony destruction that was associated with early mortality. And so it's important to understand that there's different patient populations with different indications, and that's why coming up with a consensus that everybody agrees on is important. Another one. So now, once you have a surgical goals, when you know you're going to operate, well, what should be what are your goals? You want to decompress the neural elements if there are neurologic deficits. If there's widespread infection or septicemia, you want to remove the septic focus. If you're getting progressive deformity or instability, you want to stabilize the spine. And you also want to prevent the complications of immobility. A lot of our patients that have these conditions don't want to move because they have back pain, and then they're prone to having DVTs and PEs. Then they can have atelectasis, develop pneumonia, and so we want to prevent that. And that's another one of the goals of developing an algorithm that we can use to dictate treatment. We can go into this a little bit later when we go over cases. But what are the ways that we can treat this? Well, there's many novel ways that people are definitely doing minimally invasive or endoscopic, particularly for epidural abscess, for infections that get successfully treated with antibiotics, but they have some sort of instability. People have been doing percutaneous instrumentation without debridement. Now, if you do have an infectious focus and you need to decompress, you do decompression, debridement, and instrumentation. At times, you have to go more invasive and do discectomy, corpectomy, and even anterior posterior reconstruction. So we'll talk about this a little bit later. So what is the clinical predicament? So as these infections become more common, for instance, the 7 or the 8 last trauma cases that we did at Rothman, at Jefferson, were an infection. You're on call, they come in, and it's not like the standard trauma, like facet dislocations. It was an infection with an epidural abscess. So it tells you it's becoming increasingly common. And even though there's many classifications, there's no agreement on what the treatment or how do we communicate with each other regarding these infections. One of the first ways that people tried to classify was Stalgard in 1991, and it was a multi-center study. They introduced a classification based on the timing of the spinal infections, and in the group of pathogens that were that were affecting the patient. It was one type of pathogen, 2 or more types of pathogen, or multiple types of pathogen with myonecrosis, and then also in the early infections and what did they respond to and what they don't respond to. Another one was Lenner in 2018, and they are a classification based on the location, right? Whether it was a spinal abscess, the intramedullary, the subdural, epidural, or if it was in the disc, in the paraspinal infection, or in the end plates, spondylodiscitis. And that's one is based on the bacteria, the other one is based on the location. But this doesn't really tell us what the treatment should be or what could help. And so this is a paper that's talking about, well, what is an algorithm? And this is a very early attempt at coming up with an algorithm. And you have, if an epidural abscess without spondylodiscisis, once you have an indication for surgery, you can say, okay, well, epidural abscess without spondylodiscitis, it's a decompression and drainage. Now, if you have epidural abscess with spondylodiscisis, you may have to do a decompression with excision, with instrumentation either posteriorly or in your body with drainage. And then if you have bony destruction, then you have to go to a corpectomy, anterior posterior decompression, fusion, and stabilization. And then postoperatively, everybody gets antibiotics and monitoring for neurologic status, clearing of infection, and rehabilitation. And a little more background on this. So that was when you go to treatment. So people always say, well, what does it mean to have an instability in the spine when you have an infection? And that's a very good question. When people develop the instability in trauma, Telix with Alex and the group, well, that was pretty standard, right? There's the tension band posteriorly, and if there's the disruption of the posterior tension band, or there's a translation injury, those are clearly unstable. The neurologic deficits you see are directly related to the instability of the spine. So that told you when you had to stabilize the spine. But an infection is a little bit more difficult. Infections tend to be a very slow process. Patients may present with back pain without bony destruction. They go home and they come back 3 weeks later and the bone is gone. And that's when you're like, okay, well, they're unstable. But this is not standard, and not everybody develops in the same timing. And so bony destruction can be can be difficult to see even without a diagnosis, or even with a diagnosis, it can take a long time to see it. Neurologic deficits are rare, really. It's usually when you have significant epidural abscess and compression of the elements, and not necessarily because of the instability. And also, So once you know you have an instability and you may have an infection, well, what type of bacteria is important, because the breeding it and then treat it with the right antibiotic is different depending on what bacteria you're treating and how long you're going to treat it with antibiotics. A little more on instability. There's been a big push in the spine community to come up with an infectious stability score. One of the first attempts was by Shomig in 2022, and they developed the spinal instability spondylolischitis score. And this, it was case based. They evaluated 127 spinal infections, and they tried to come up with a score similar to the SINS classification for tumors. And they had some drawbacks. They only did a two-surgeon survey, and there was no Delphi consensus. So they may have been some bias, but at least it's a good attempt to start. They wanted to propose a comprehensive classification for spinal instability, and that would aid the spine surgeons to come up with optimal treatments for spontaneous spondylolischitis. And this is more or less the score they came up with. It's similar to SINS. It's where the location of where it is, junctional, either occiput, thoracic, or lumbar. If it's in a mobile segment, C3 to 6 or L2-4. If it's semi-rigid in the thoracic spine or rigid in the sacrum. If it involves more or less than 50% of the body, if the end plate's involved or not involved. If there's a subluxation or translation of the bony elements. If there's new deformity after infection, or if there was there before, or normal alignment. And if there's mechanical pain all the time, occasionally, or no pain. And depending on the score, 0 to 4, stable lesion, 5 to 9, potentially unstable, and 10 or higher, it's unstable, necessitates surgery. So it's a very good way to start it. Their mean score in the study that 127 patients was 8.1. 10 cases were defined unstable, 84 potentially unstable, and 33 as unstable. And the only one of the other drawbacks was that the score did have a significant false positive rate of 15% and a 40% false negative rate. So more work needed to be done to be able to come with an improved score. This was also tried by the site score with Plumer and Chapman, one of our other guys that worked with us at the Knowledge from Trauma. And then this was a slight improvement over the SIN score. And then similar, they were trying to come up with a categorization where they could come up with points to assign to when surgery was necessary for instability. And another one that came up, and this is Raja from our group as well. Tuberculosis is a monster in and of itself. We don't see it that much in the United States, but it tends to have significant bony destruction. And he came up with a classification associated to be findings, and that was another way of saying, okay, well, this is an unstable injury in tuberculosis, and this one is when people need civilization. So this just tells you that people are all over the place. That we still don't have a consensus of when we need to intervene for instability, and that's why coming together to develop something is important. Now, coming back to the point of failure of conservative treatment, this is a very nice study published very recently by Jens on well, how do we know that people need to be stabilized, and when do we know that they failed antibiotics? So they followed 35 patients that had a de novo infection, and they treated with 25 of them did great with antibiotics, but 10 failed. And when they looked into the people that failed antibiotics, either clinical or radiographic deterioration, there's 4 things that came out that were highlighted. It's IV drug users, if they had a high fever, if they had same level of infection facet involvement, so not only an anterior infection, but the posterior elements of the same level were involved, or if the extent of the caudal and rostral vertebral body involvement was seen on MRI. So not only with the site of infection, but above and below, adjacent segments were also involved. And those were the reasons why the people failed. So this is something that we need to take into account, because if you have a patient and you're following them clinically and they have some of these characteristics of failure, perhaps this is a sign that you should intervene sooner rather than later. Again, going back to surgical management and perhaps type of surgical intervention that we should proceed with. Again, either just a drainage and stabilization, or spinal reconstruction. This is a bit of a summary of what we do. So for the most part, you wanna you can have anterior and posterior approaches. If you have to do significant debridement because there's a lot of bony involvement and destruction, perhaps you have to do anterior column restoration. In the cervical spine, many of us have to do corpectomies, and you have to sometimes go above and below the disc because there's extensive bony destruction. If that's the case, then you need to do a posterior stabilization. If you do a corpectomy with a cage, then you have to supplement it posteriorly to make sure that that cage doesn't displace. In the thoracolumbar region, If you have large defects, you may need an interbody mesh, or these days we can do an expandable cage laterally via, a lateral approach, or certainly via TLIF approach. Many of us do transpedicular decompressions or costotransversectomy, but they tend to be very involved and large surgeries. And for the most part, you instrument 2 levels above and 2 levels below so that you can stabilize the spine. Except in the lumbar spine, you may be able to spare a level or so in order to spare mobility, especially in younger patients. But that means, front, back with stabilization, expandable cages is one of the ways to do this. Now, what do we do for the inner body? If you have to do a reconstruction, the gold standard used to be iliac crest bone graft from autograft, and I haven't done that in a while. We've moved on to titanium cages. What were the thoughts behind iliac crest bone graft in the past? Well, it's biological superior to host defense. You have osteoblasts that can make bone. You have BNP and growth factors in the tissue that can induce cells to become bone, and you have a scaffold of bone where cells can grow into and become more bone. You decrease the risk of rejection and transmission of disease because it's an autologous. For the most part, you have superior fusion rates in infectious regions. If you have autograft bone, we've all seen really successful bony fusion. And there was also a lack of alternatives. Back in the day, that's all they had. They didn't have the advanced biomaterials we have these days, or the metals we're using that are less prone to be for biofilm adherence. And so at the time, we used to think that implanting metallic devices would lead to persistence of the bacteria because they would attach to the metal. But a lot of studies have come out that modern implants are resistant to a lot of the biofilm. They're able to combat the infection. A lot of these are combined with the antibiotic eluting materials, and many of us have patients where we take bone graft and they do great, except the second side of harvesting, that's what hurts, and they are not happy, and they complain, my hip hurts even though my spine is fine, and donor site morbidity has become an increasing problem. And if you don't have to do it and you can use a titanium implant with synthetic allograft, then that's sometimes a better option. Not to mention that increased operative time. If you have to have somebody harvested, it takes an extra 10, 20, 30 minutes. This is what I was talking about. There's a new study published last year about drug-eluting bioactive glass, where you can put antibiotics, and it was used in spondylolischitis. It was pretty successful. And then there's other ones where you can put BMP2 in certain implants and pyogenic spondylolischitis to promote bone growth and fusion. And so these are novel biologics with novel biomaterials that can be used to treat infections and spare the autograft. Another, what else can we use? Well, there's a lot of data available for instrumented surgery with infections that it can be done very safely with higher rates, without higher rates of infection and recurrence, without any primary failure or secondary failure, lower reoperation rates and lower mortality rates. I have examples on the screen. There's you can perform it and index procedure, perform a debridement, perform stabilization, and place implants. And there's papers that show that it doesn't matter what instrumentation, there's very low rates of recurrence. And there's recent studies that have used PEEK as well, and allograft, and they show that regardless of the state of the instrumentation you're using, there's novel implants that can withstand the bacteria, and then they can have successful outcomes. Of course, you always worry about loosening, and that's why following up the patients over time is important. And I think that's what I had in terms of the presentation of why we're trying to develop a classification. And now, Alfredo, here's the classification that we come up with AO Spine. It's relatively new and it's still in the works, but it's very similar to the other ones. In this case, we're doing a definition by location. A is lumbar, B is thoracic, and C is cervical. And then we have a morphology. 0 is infectious, is extraspinal. 1 is when the infection is osteomyelitis and or discitis and it's not in the canal. 2 is when there's an infection with or without osteodiscitis, but there is canal involvement. And 3 is when there's infections with or without osteodiscitis and there's nerve compression. And then we had a plus sign when there's bony destruction. I want to go slow because it's hard to picture it because there's many moving parts. But an A0 would be, again, go back. A is lumbar, B is thoracic, C cervical. It's a little counterintuitive, but just think C for cervical and then, A for lumbar, and then we can go that way. So A, this would be a lumbar. A0 is an extra spinal. So here you see like, spinous process, inflammation and infection, or around the bony elements outside the spine. This usually can be treated with antibiotics. An A1 would be osteomyelitis or spondylolischitis without an epidural abscess or involvement and no nerve compression. This is an example. You see some involvement of the end plates and the bony elements and the disc. And then this is another A1. And this one would be bony involvement, which would be the facets without involvement in the canal. So it's also, again, osteomyelitis, bony disease without discitis, but it's also an A1. And this is an example of an A1 plus, where you have discitis, osteomyelitis, and you have some bony destruction at the end plates. A2 is an infection with or without osteodiscitis and canal involvement. So there's two types. One, we have facet involvement and then a little bit of an epidural abscess draining from the facet. You can see that on the left side. And on the right side, you can see discitis, osteomyelitis with a little bit of an epidural abscess centrally anteriorly. But there's no compression of the neural elements. And you have A2 plus when you have bony destruction at the disc level and the end plates. And A3 is when you have osteomyelitis with or without osteodiscitis. And neural compression, this is similar to the one before, but this one you do have an epidural abscess that's leading to compromise of the nerves. And plus is when you have bony destruction. A3 plus is where you get to thinking about doing an anterior posterior decompression fusion with a spinal cord with vertebral column reconstruction. And again, like all AO spines, we take account of the neurology. If there is a neurologic deficit, radiculopathy, or even cord injury, we have to classify that. And 0 is intact, and like all the others, 1 a little bit of neurologic, so partial weakness or weakness initially that has resolved. Radicular complaints, people complain of pain. Incomplete spinal cord injury like cariquina, or a complete where they're loss deficits below the level of the lesion. NX is when a patient presents obtunded or unconscious. Then when you don't know, you can classify it as an NX. And you also have modifiers. Right now we have only 2. I'm not sure whether it's an M2. I think there's an M2 that we took out, but the M1 would be inability to move due to pain or instability, and an M3 would be with tuberculosis. And again, it's largely based on the spine classification legacy nomenclature. This is a slide that shows the study. The principal investigator is one of my senior partners, Greg Shorter, and one of the co-investigators is my boss, Alex Vaccaro. We're in the next year or so, we're going to start an international study. We're doing an internal validation of the classification and assessment of the differences between all of us, and then the third step is doing an observational study between multiple sites where some people treated with surgery, some not with surgery, and we come up with a longitudinal evaluation to see if we can validate the score. Now we go to cases. Alfredo, I don't know if you want. I can show this one. Do you have cases as well?
Yeah, I got 2 cases, but let's start with yours.
Yeah.
And if we have time, we can move to mine. All right?
Yeah, we're perfect. So these are all cases courtesy of my partner Greg Shorter. This is a 56-year-old gentleman with minimal past medical history, pretty healthy, that presented to the ED with 2 weeks of worsening back pain and fevers and chills. Imaging diagnosed him with L3-4 discitis and osteomyelitis, and he was neurologically intact. Blood cultures were drawn and they grew bacteroides, and because of the elevated blood cultures and his back pain, we got the MRI. Let me go to the next image. We didn't have any bony lesion. CT scan, the spine showed age appropriate degenerative changes, no acute findings, no bony destruction, and then the MRI showed an epidural abscess. It's small prevertebral collection without neural compression, a little bit of end plate hyperintensity at the L3, L4 level. And there was some motor changes at L4-5 and L5S1. And bacteria was bacteritis. We treated with Unison for 2 months. We did serial workup for blood markers, ESR, CRP, white cells. Those improved. Lab markers normalized. We didn't do any other imaging studies. When he completed his IV antibiotics, the infectious disease team recommended augmented for a year as suppression, and he's doing fine. No additional problems. That's one of those cases that would be. Let's go back to the classification, Alfredo, and I think this would be canal involvement, so it wouldn't be an A0, and it would be an A2. without bony destruction. So it's an A2 classification. And so this was able to be successfully treated with antibiotics. Let me go to the next case. So this is a 63-year-old gentleman with a past medical history of hypertension, hyperlipidemia that had several months of neck pain and had gotten progressively worse prior to coming to the ER. When he came to the ER, he quickly got an MRI, and that showed a dorsal epidural fluid collection from C2 to T1 with substantial core compression. Examined the ER, showed left-sided weakness and inability to ambulate. His inflammatory markers were significantly elevated, and his blood crystals grew MSSA. We got a CT scan that showed minimal bony destruction, and an MRI scan that had a large dorsal epidural collection, again from C2 to T1. I'm going to show it next. So you see here bony destruction, and there's a large epidural abscess from C2 to T1 on the right side. He was moving, so it was hard to get a better picture. And so MSSA, we take him urgently because of the difficulty with ambulation and weakness. He was taken urgently to the OR. We did a C2 to T1 laminectomy with posterior fusion. We did nafcillin based on cultures and ID recommendations for 2 months and serial blood workup. The neurologics recovered. The neurologic deficits recovered, and his lab mark is normalized. No more additional studies were done. And again, IV antibiotics and augmentin for a year. And the patient did fine. These are his post-op x-rays. Sorry, I'm in a meeting. And this is the third case. Again, that one would be bony destruction. It would be an E3 plus with a epidural abscess. This is the third one. This is a 73-year-old gentleman with a past medical history of CAD, atrial fibrillation, type 2 diabetes. She had a prior cerebrovascular accident, stage 3 kidney disease, and COPD. He was transferred from an outside hospital due to worsening back pain and right leg weakness. And there was an MRI showing lumbar epidural abscess, and cultures had been growing at the outside hospital with MRSA. He had already been treated with 6 weeks of IV antibiotics, vancomycin, switched to daptomycin, and IR had drained the site. This you can see L5 is one with bony destruction and epidural abscess on the MRI with severe compression and stenosis. And in this case, blood cultures had MRSA. We took him to the OR for an L4 to S1 decompression at L4-5 and 5-1. Because of the discitis and osteomyelitis, we did a TLIF at L4-5 with titanium. And at L5-S1, because of the substantial bony destruction, for that one, we elected to do a TLIF with iliac crest autograft. In a lot of these cases, the problem is you can't take too much iliac crest. So if you have 2 levels, you may only be able to do iliac crest in 1 level. And we augmented the posterior lateral fusion with iliac crest bone graft. And again, targeted antibiotics for 2 months with vancomycin and ceftaroline, and he did well. This is post-operative x-rays. You see the TLIF, and you can't really see the autograft. And that's it. That's all I have. That's my team. And I'm happy to see your cases now, Alfredo.
Awesome, man. What an outstanding presentation.
Thank you. I think I went a little too fast, but I had a lot of slides. I wanted to make sure that I got through them.
It was phenomenal,
man. I stopped sharing my screen. Okay.
Let me share a case for your opinion. This was a 51 years old male that he was my anesthesiologist. Actually, he is my anesthesiologist. He's healthy, trail runner, super active guy. 1 week back, he started with dorsal pain, and he ran a marathon, and he put himself steroid in his gluteus. So the pain was getting worse during that week. So he called me on a Monday morning. I was in clinic, and I told him, "Come on, let's see it." And the physical examination, he had a medial dorsal pain of C out of 10. Some partial hyperreflexia, Babinski, no fever, nothing that made me suspicious about an infection. He's not on drugs. I know him pretty well. He's pretty healthy guy. So with that signs, I ordered an emergency MRI, and I continued with my clinic. So I sent him to the hospital, and called me back. And 6 cycles later, he developed motor weakness on both legs, and the pain increase was 10 out of 10. So I ran to the hospital to see the MRI. This was the MRI at that time. And you see a long epidural abscess or
big
tumor.
epidural abscess,
yeah. I mean, at that time, I suspect also a tumor possibility. I mean, I wasn't suspicious about an infection. But
how did he inject himself?
he injects him. So he's an anesthesiologist. They're crazy guys, you know. And it's
Yeah.
he, is, but I mean, there he was already with that pain. So I thought about the cause of the infection. Maybe was the injection, but he was in dorsal pain with the dorsal pain in advance. So
Okay.
I don't know where was the site of insertion of that microorganism, but I don't know. At that time, the radiologist told me it might be a lymphoma too.
Mm-hmm.
He wasn't no B signs, no fever, nothing extra, but due to the rapid progression of the symptoms,
Mm-hmm.
um, we didn't wait for a contrast MRI. We just
Yeah.
got this MRI. So the question we have that time. So now is an emergency, is a neurological emergency. So, but we do it like at 1 a.m. or wait
Mm-hmm.
until 6 a.m. with the full team. Um, what if that was a tumor? It would change anything, or you do the same thing, decompression, and we see.
Mm-hmm.
And which surgery would you do? You do a decompression, laminectomy, laminate with plus fusion, trying to avoid like skip hemilaminectomies on one side
Yeah.
and washing, or what are your thoughts in this case?
So, I mean, I agree with you. I think that the fact that he's progressing quickly in terms of neurologic deficits, and he's a young, healthy patient, that you don't want to wait too long. I don't have a lot of experience in tumor, but one of my colleagues does, and we do cases together. And we've had similar cases where I tell him, well, what if it's a tumor? He's like, well, it doesn't matter, we're going to do debulking because there's a neurologic deficits, we had to save spinal cord, and then you use it as a biopsy for that. And so short of a metastatic primary tumor, then that's what we've done. I think in this case I would have done the same thing. And then what type of surgery? He's so young that I hesitate to say you want to do a lami fusion. I would have probably do a multi-level lami and wash him out, or like you said, you do a lami above, below, and then you do skip lami and irrigate it and breed it. I mean, I guess we have some people. So I think Raymond's on the call. I think probably an endoscopic washout would also we be an
Mm-hmm.
option. But yeah, I think I probably just done a level 1 or 2 level lami and do an irrigation and wash it out.
We're in the same page. So we classify this as it's a B3, it's a dorsal, it's
Yeah.
epidural, it's no
Hmm.
bone involvement. Um, so
With
that's what we
neurodeficits.
did.
Yeah. Hmm.
Yeah, exactly. So that's what we did with the laminectomy, multi-level laminectomy. It was pre-organized, was pretty stiff. So we need to take out all the laminas, like in 5 or 6 levels.
Hmm.
Um, the cultures show us a Streptococcus intermedius. He underwent IAB for 6 weeks. He did phenomenally. This is
Hmm.
the patient back
Nice.
to sport. Yeah, he's a friend
That's
of mine.
awesome.
That's what I was authorized for him.
That's awesome.
Um, so this is second case. This is different case. This is 45, but it's pretty similar patients. Kyle, functional demands, a pretty active guy. I studied with 45 days of severe right side lumbocuralgia.
Hmm.
Had mechanical pain, no full relief with rest or during night, no fever. The inflammatory markers was the ESR 97 and CPR over 200.
Hmm.
He have 2 out of 2 cultures for Methicillinus and Cibus staphylococcus. So I didn't know the patient at this time. So the infectologist specialist asked for images and started IV. The clinic
Hmm.
was pretty clear. The labs were cleared. So these are the images by that time. There's uh, some asymmetry at the 4 or 5 days.
Yeah.
There's not pretty good shadows of the end plates at 4 5. I was looking back was the
Oof.
MRI that was pretty clear for an infection. So the anesthesiology said I got an image, I got a clinic, I got the labs. So I start antibiotics, and we'll see.
Hmm.
They have posterior involvement, as you mentioned. and he had some epidural abscess in the 4-5 foramen that may explain the choralgia.
Yeah.
So he started antibiotics. This is the sagittal cuts, some prevertebral abscess.
Yeah.
But the canal was pretty clear.
Yeah.
So this is the axial cuts when you see some posterior involvement. As you mentioned, was a factor for that may trigger the need for surgery or fail
Yeah.
in the conservative
Yeah.
treatment.
Instability. Yeah. Uh-huh.
Yeah, exactly. So he started antibiotics, and at 6 weeks, the patient had no clinical improvement. Now he also present left side choralgia on the other side. The culture is still positive 6 weeks after, and the labs were better, but they're not perfect. There's not as good as expected at 6 weeks. So the infectology especially referred the patient to us. We repeat images.
Yeah.
These were the X-rays. It doesn't show any changes. The MRI was different, and
Ooh.
I think the prevertebral abscess is worse,
Yes. I agree.
and the disc is kind of collapsed. But the canal was still pretty clear, right? It's pretty clean. So this is the axial cuts, pretty same as the first one, and this is the CAT scan
Yeah.
with some bone destruction. And also some destruction of in the facet joints and some opening in the facet joint on the right side. So at this point, what to do with this patient? I mean, he was 6 weeks under antibiotics with target specific antibiotics for the cultures, but the cultures still positive. My main questions here is why he failed to conservative treatment. We have the cultures. The patient is pretty healthy. It's not other sources of potential fail. Why he failed? I mean, these are different culture going on. These are different organism going on. This instability contribute to this.
I
I
think
don't
so.
know. What are your
Remember that
thoughts?
paper, that the Jensen's paper, right? That's why I like to put it. So I'm looking at it while you're saying who will fail antibiotics, and it's IV drug users, fever, same level facet involvement, and increased involvement of the caudal and rostral vertebral body. And so in this patient, I think, I don't know, we didn't speak about fever, but if you can see, you said we have the facet involvement, and then you have significant involvement of the level above of the bony above and below the disc.
Yeah.
So I think that predicted that this was going to fail. And also another reason that indicates surgery, not only failure of antibiotics and instability perhaps, but also persistent septicemia, right? And you need to control the source of infection, otherwise this is never going to heal.
So I completely agree. And for these cases, you go looking at the MRI, look like the abscess is in the prevertebral, right? It's not in the disc or not in the canal. You go clean that anterior, or you go all posterior?
So I have the luxury that at my hospital I have a very, very, very good vascular surgeon, and so when we have similar cases like this, and I showed the imaging, and he says that it's doable. We go for anterior, and we do corpectomy, large cage reconstruction, and we debride the anteriorly, and that does a good, excellent job. Now the problem is, in many instances, if you don't have an access surgeon that can save the access, then it's difficult. But I think I would have do a front back in this one if it was that much disease.
Awesome. So that's we did. We get anterior to psoas. We're pretty used to
Wow.
do it for degenerative cases.
You don't need an access surgeon, Alfredo. You can do it all.
No. I eventually I use it, but for this case, I'm pretty safe going anterior to psoas. It's a good window. I can go without vascular. This was the axis. You can see the psoas, the prevertebral disc. We clean the disc. We use iliac graft for this case. In the same position, we took the graft. It hurts always, but In this case, we did it single position with in the same lateral position. We put the screws,
That's
so we're
awesome.
trying to avoid the flick. And you can see the graph down there. This is the long-term X-rays and full span X-rays. This is the MRI.
Oh, awesome.
I think
He did great.
almost 10 years follow-up. And the fusion at the 4-5 disc. We thought in this case we didn't need to do a big reconstruction of anything. We just need to stabilize and clean.
Yeah.
But when you need to do a big reconstruction, you prefer to use expandable cages or stacked cages?
I've used the Globus expandable cage when I've had to do that.
Got it.
You know, it's once I did the Striker too, but you know, it's I've had that option to. They're titanium, they expand really big, and they kind of fit into space. The only concern is sometimes they kind of tilt when you put them in, and so it's kind of difficult to put it in the right spot. But I had pretty good success with those.
Awesome.
What about you? What do you use other than the autograft?
I try to use expandable.
Yeah.
Titanium, we changed to titanium like 10 years back.
Yeah.
I think there's a tendency to go to autograph again. This is the trends, it's go.
Yeah. Up and down. Yeah, I agree.
Yeah, when you see in Europe, they're using a lot of graft, and in the US, they're using a lot of titanium. It changed.
Yeah, and we're starting to use a lot of synthetics, like tricalcium phosphate, like magnetos or I factor to
Yes,
pack it in the cage, and we had pretty good success.
but you pack it in the cage, or you can customize, like print that.
No, I pack it in the cage. Yeah.
Use the cage and pack and then you can
Pack it
get
in the cage.
like allograft, customized or printed or just for cervical.
What do you mean?
Like cages, like with
Oh,
allograft.
you're 3D print. Oh, no. So I for autograft I do 3D print the cages, and then I pack the autograft, and I use synthetic matrix to pack the rest. And
Awesome.
or if I don't have autograft because we haven't done a decompression, I just pack the synthetic matrix in the cage, and then I put it in the place, and whatever else I have, I pack it on the sides.
Awesome. So I think we're in time.
Mm-hmm.
Jose, it was a phenomenal hour
Yeah, thanks, man.
with you. Thank you very much. You gave us a lot of information, a lot of new things to think. Appreciate it, man. And I
No,
hope
thank you for
you
the invite. I
see you
really
back
appreciate
here.
it. Yeah, no. We'll happy to participate and help you guys. Alfredo, thanks for the invite. I think this is a great forum where we can communicate all the things that we do at AO, and also that we can maintain relationship with everybody around the world. And I think this is a great resource for everyone.
Absolutely. So we'll see this presentation in YouTube. I'll send the link, everyone. Thank you for joining us. We'll see you next week, our weekly session of Virtual Global Spine Conference. Thanks.
Thank you so much. Have a good night, guys.